Hello and welcome to Unstress. My name is Dr. Ron Ehrlich. I'd like to acknowledge the traditional custodians of the land on which I am recording this podcast, the Gadigal people of the Eora Nation, and pay my respects to their elders, past, present, and emerging. Well, today we're going to explore craniofacial development. You might ask, what is that? Well, craniofacial development refers to what is going on in your head below your eyes. So it includes your upper jaw, your lower jaw, your sinuses, your pharynx, your paranasal sinuses. So everything that's going on below your eyes in your head. And you might say, well, why is that important? Well, the reason it's important is because, as any regular listener of the podcast will know, the size and shape of your mouth determines the size and shape of your upper airway. And that has implications for how well you breathe, not just during the day. Are you a mouth breather or are you a nasal breather? The more I learn about this, the more critically important that question becomes, and we discuss that in today's episode. But also, the amount of space that you have in your airway determines how well you sleep. And sleep disordered breathing conditions are a serious problem. I mean, they certainly affect every aspect of your health, mental, physical, and emotional. Getting a consistently good night's sleep right, which is a function of both quantity, getting enough. For 90% of the population, that's 7 to 9 hours. But importantly, much just as important as putting your head on the pillow is breathing well while you are asleep. And that's where craniofacial development, the size and shape of what is going on in the lower 2/3 of your face, is really important. And that's the subject of today. My guest today is Professor Dave Singh. Now, Dave has trained in England, in the UK. He started as a dentist, but he then went on to obtain 3 PhDs. Yes, not one, not two, but 3. The first in dental medicine. Then he went on to focus on craniofacial development, but specifically looking at cleft palates. Now, cleft palates are when the palate doesn't join and there's a gap in the bone and either the palate or the lip. Now, it's not a particularly common condition, however, and perhaps on the one hand, it is an extreme of something that is actually very common in our Western world, and that is underdeveloped upper and lower jaws, resulting in crowding of teeth and narrowing jaws and narrow upper airways. And then he went on to do his final PhD in orthodontics. He's published over 200 articles in peer-reviewed medical, dental, and orthodontic literature, has published or contributed to 7 books, and his most recent book, which he discusses, is pneumopedics. Pneumopedics, that was a new word for me, but pneumopedics, a combination of orthopedics and pneumatics, I guess, and craniofacial epigenetics, which focuses on craniofacial sleep medicine with a special interest in obstructive sleep apnea in both children and adults. They're subjects that we've touched on before. He's also written a book called Epigenetic Orthodontics in Adults. And this word epigenetics is a word that I think we should become familiar with because, we feel that our genes are an important part of who we are, but we are not a victim to our genes. It's more important is how our genes express themselves. And that's the wonderful new science of epigenetics. And it turns out that you actually have a significant impact on how your genes express themselves through the thoughts you have. They're little chemicals called neurotransmitters that attach onto cells and cause genes to express themselves. So that is thoughts are things, but so are nutrients, and so are environmental toxins and chemicals, and so are small forces, which is what we focus on in the epigenetics of the mouth. So, with Dave Singh, he is also now currently an adjunct professor at Stanford University. It was a wonderful opportunity to catch up with him. I'd done his course in Australia over 10 years ago, and it was a great opportunity to reconnect with him. I hope you enjoy this conversation I had with Professor Dave Singh. Welcome to the show, Dave.
Thanks, Ron. Great to be here.
Dave, we first met in Australia in about 2010. I think that was the first time I attended your 3-day program, and you introduced me to a whole lot of new concepts in dentistry, but in sleep medicine as well. And I want to cover some of those, but
Sure.
You have an incredible professional journey. I mean, tell us a little bit about your journey to this point that's brought you to be an adjunct professor of sleep medicine at Stanford.
Well, it is a long story, Ron, but I'll cut to the chase and say that originally from England and did my dental training there, opened my private practice like most people do, and it was very successful for a period of about 5 years. And then I got the plateau thinking I need to do something different more. And I got a chance to do a master's down at Bristol. But in fact, after the first 6 months, I was upgraded to the PhD program, and that was in cleft lip and palate. We did the clinics, at Friendshire Hospital in Bristol, as well as doing my PhD.
Cleft lip. Now, cleft lip and palate.
Yes.
Just a very brief 101 cleft lip and palate. It's when, tell us, John.
So when the fetus, is in the womb, the two halves of the palate actually have to come together and fuse in the midline. And the lip does that also, but also fuses with the nose as well. And if that process is interrupted, the two components don't fuse together, and the lip is separated at birth. The palate may also be separated. And so that's a cleft lip and or palate. And my work was to say, what causes it? And if we understand that, what's the clinical ramifications? And that is what really brought me to the US many years later. And so after my PhD, I did a postdoc sabbatical actually in Canada. They sent me down to the US. I met Jim McNamara at University of Michigan. He was the president of the American Association of Orthodontists at the time.
And he was really a legend in orthodontics globally.
Still is.
Still is. Yeah.
But we wrote 20 papers together, and he was second author on all my papers. And long story short, when I went back to England, I was offered a position in the US in a craniofacial cleft palate clinic. And so it was too good to turn down. And so that's where I went from there. And the interesting thing, Ron, is that one of the things that we think about with the cleft lip and the cleft palate, we see the facial deformity immediately, facial recognition. What we don't see is the dysfunction. And what we realized with a team of physicians, plastic surgeons, orthodontists, speech pathologists, a nice big team, what we realized is that these kids don't breathe through their nose because the mouth is open. And so the idea was to non-surgically see if we could open up the nose. And when we did that, the lip and palate came together slightly. We then put a device into the mouth and non-surgically closed the palate. And then at the end of the procedure, the plastic surgeon surgically closed all the components. And what we found is that those children, those babies, if you allowed them then to grow, you could not distinguish those who had been born with a cleft palate compared to a regular control group. And so this is where the idea of the epigenetics came in, to say that there's a blueprint that we inherit genetically, but environmentally it gets disturbed, it goes off into a different pathway. And what we have to do is see if we can re-coordinate it and bring it close to, the body plan as much as we can, and then improve function and then take it from there. So in a nutshell, that was the kind of big starting point of the journey thereafter.
Because you looked at cleft palate, you then came to look at the potential to improve breathing patterns, and that has an effect. And then is this true? Have you done 3 PhDs?
I have 3 doctorates, so Doctor of Dental Medicine.
You're an overachiever, Dave, I can tell.
Well, I followed my pathway, my kind of intuition. And with a PhD in cleft palate, not being a plastic surgeon, there was a limited amount of things I could do clinically. And so my third doctorate was in orthodontics to say, okay, then I can be an orthodontist working in the craniofacial cleft palate clinic. The most interesting thing, Ron, there was that after these babies that we've been treating, of course, there's other children who had been treated historically and even teenagers. And now we would see the full spectrum of what happened with these children whilst they were growing after the surgery was done when they were young. And I would say, just give a round number, 8 out of 10, 7 out of 10 had a mid-facial deficiency, to say that the middle part of the face, the upper jaw, the upper lip was set back compared to the rest of the face. And so they were planning surgeries to say, how do we now correct these children as they move into adulthood? And so that's where I came into the equation with the 3D, imaging to say what goes where. We were using MRIs in those days. And so we did a whole sequence of children, teenagers, and the group was about 7. And we did a new technique in those days called distraction osteogenesis, which is well known now. But what you do there is you create a preformed, pre-planned fracture of the jaw. You then place a device, and then after a period of latency, you turn the screw on the device to actually protract or elongate the face, depending on which direction you want to go. You could do it for the lower jaw. We actually did it on the upper jaw, mid-facial distraction. And, after the review, when these children came back, the first thing I noticed is they were all smiling. I'm thinking,
they were all smiling?
They were smiling. And I'm thinking, this is very unusual because, they don't have so much self-esteem sometimes, and sometimes they don't have a lot of confidence. But 7 out of 7 came in with a big smile on the face. And I thought, there's something more going on here. And so I went back, reviewed the post-treatment MRIs, and in 7 out of 7 cases, the airway behind the jaws had ballooned. And I said, oh my gosh, these kids are sleeping better. They wake up and they're like new people. And so,
and I guess this focus on cleft palate, which is an extreme form of underdevelopment of a jaw.
Yes.
I mean, it's an obvious and it's an extreme form of underdevelopment of the jaw. And when you use the term, I should remind our listener, when you use the term devices, what you're talking about are plates that are custom fitted for the upper or lower jaw, orthopedic plates that have the potential to expand arches. So this was an incredible insight into, actually, I know, how common is cleft palate?
It's relatively rare, and it's a very interesting situation because here's the epigenetics coming in again. So we did some overseas missions, if you will. So we went to some of the more developing countries like Indonesia and Malaysia and a few other countries like that. One of the islands in Indonesia had a huge prevalence of cleft palate. Every other family on the island knew someone who had a cleft. And so the international team went there, they did their investigation, and the long story real short is there was a zinc deficiency on the island. They added zinc to the table salt, and in one generation, the rate of cleft palate was about the same as it is elsewhere, let's say 1 in 500 live births. And so here's an idea. What we know now is the metalloproteinases, which are enzymes that need specific minerals, for example, zinc, to do their work. If they're deficient, this is where the epigenetic comes in. You provide a very small environmental signal, and you will get a pretty decent clinical, response if you get the signal right. And so if you look at different communities, African American, Asian, different groups of people, there is variance there in terms of the epidemiology. But the bottom line here is that we can at least work with the environmental factors to, decrease the chances of a child having that kind of facial deformity.
But it's interesting because although the cleft palate is an extreme example of an underdeveloped mid-face maxilla. So again, for our listener, the mid-face is from the eyes down to the top and includes the top jaw, and that includes the nasal passages and sinuses. But here's a question. I mean, while cleft palates are unusual and a good example of an underdeveloped maxilla or jaw, how we've evolved to have 32 teeth as humans.
Right.
How common is it for people not to have enough room for all 32 of their teeth? How widespread is that problem?
Depends on the papers, the literature that you read. The number that is really thrown around is like about 10%. Clinically, or according to the literature, about 30% of people have sufficient room for 32 teeth, fully erupted and in occlusion. And by the way, most of those people will be in what should we say, developed countries, or less sophisticated societies where there's less refinement of food, where the diet is more fibrous and, a non-refined diet. But that's a very interesting point of view, because when we look at human evolution, or just evolution in general, at the very earliest stages, the teeth were simple conical structures that you see in, reptiles and amphibians, that sort of stuff. And as time went on, we developed, through evolution, bicuspid teeth with 2 cusps. And then in evolution, 3 cusps, that's called the trigone. And then 4 cusps, that's called the talon. And then modern humans comes along, and we've got 5 cusps, 5 shells on each of these crowns of the teeth. That's called the Dryopithecus pattern. First discovered in Germany, in the Neanderthal kind of valley. And so what we have is the biggest teeth in history, in evolutionary history, according to our size. So what happened with humans is we got an increased number of teeth, an increased number of cusps on the teeth, and we have the thickest enamel compared to our body size for the mammals. And so what we're finding out, of course, is that the enamel thickness is related to your lifespan. And so there's no surprise to say that if you took all the artificial stuff away and had to rely on a natural diet, if you had no teeth, your lifespan would be shorter. So let's take another example here. Let's take an elephant, which has the same or a similar lifespan to a human, let's say about 70, 80 years. The difference between the elephant, it's got 3 molars, same as humans. The difference is that the elephant's molars erupt one at a time. In other words, the first molar erupts when it gets worn out. The second one erupts when that gets worn out. The third one erupts. When that gets worn out, the elephant can't eat and therefore will die. And so what dental tissue shows us is an indicator of lifespan. And so, oh my gosh, now we need 32 teeth, but you can't accommodate 32 teeth if your jaws are too small. And so then that brought the question of why is it that our jaws are so small that the vast majority of people in a industrialized society will have crowding and the teeth will be crooked and they won't erupt fully. That was the big question and debate. It's still ongoing, but I think we've got some really good clues now.
Yeah. But in your, you've said in the developing world, that's where you will often find people on a diet that's not processed. They'll have enough room for 32 teeth. But having worked now in the UK and in the US, and I know I've worked in Australia for many years, what would be your observation of people in our Western culture who have sufficient room for all 32 teeth? If you had to pick a figure off the top of your head from anecdotally.
It will be the minority. But here's what happens, Ron, is that because we are in I'll call it a privileged situation, what happens is a lot of these people as children get good dental exposure, and the dentists then refer to our orthodontic colleagues. And the training is that, well, if the teeth are crooked, we'll remove 1 or 2 maybe premolar teeth, and then we'll take out the wisdom teeth anyway. And so now you reduce the number of teeth and you reduce the jaw size at the same time. And so it's a little bit of a catch-22 situation where the teeth look well aligned, but actually it's because the number of teeth has been reduced therapeutically. Okay. Another question is that beneficial or detrimental to human health?
That was my next question.
Well, you ask the questions and I'll try to answer them. Okay.
No. But I'm happy for you to ask that, to pose that, because I guess the question is 32 teeth. We don't, when I say, in my opinion, it's like 95% or 90% of the population that I see don't have enough room for all 32 teeth. And the next question is, well, what's the big deal? Why does that even matter?
Well, I think it's important because our human genome goes back not 100,000 years, but several thousands of years. We are the modern human, Homo sapien. And so the thing about the Homo sapien is, it means wise, the wise people, okay? Well, what makes you wise is this big brain. We've got a huge brain. Now, it doesn't come for free. This huge brain is very delicate. And so we are going to immerse it in fluid to make sure that it looks after itself. And we'll put a nice brain case around it to make sure that this very fragile brain is going to be well protected. Okay. And so what we do is, because we've got a hard diet, at least, in the default setting, every time we bite and chew and crunch, there is trauma that's going to be exerted onto the skull and by extension onto the brain. And so what we want to do, number one, just kind of, empirically, is to say, let's distribute that force widely, and therefore the brain will be protected. And so our teeth got larger as the human brains got larger. That's the correlation. That's an interesting correlation to say the number of teeth got bigger, your number got thicker as these human brains were getting bigger at the same time. So the idea is to dissipate, the stress and the force through these large objects, and also through the bony facial skeleton, so our brain is protected. So let's do an experiment now to say, okay, what if we did not do that? Let's say we didn't protect the brain. And here's a study that we did at the University of California, San Diego, with our colleagues there. And we had two groups of patients. We had one group of patients with multiple sclerosis and one group of controls who were, just regular, healthy, normal people. And what we did is we measured what would happen to the flexure of the skull cap when you bite down. So when you chew or you clench or you brush, we measured the actual flexion of the cranium, of the skull cap. And what did we find? In the MS, multiple sclerosis people, the skull was more flexible, maybe twice as much, 3 times compared to your controls. And so part of the idea there was that people with multiple sclerosis may have, this micro trauma chronically over a period of time, which then, increases the risks of them developing multiple sclerosis at a later date. Of course, there's many other factors as well, but that's one structural thing that we kind of came across. The other thing that came out of that study, which was very interesting, was for the healthy individuals, we measured the width of the sutures, the joints in the skull. And surprise, surprise, it came back at a magic number, 250 microns, which is 1/4 millimeter. If you go to the other joint in the face, like the midface, the maxilla, the width there is about 0.25 millimeters. And then you go down to the teeth and measure the periodontal space between the teeth and the upper jaw. Surprise, surprise, it's the same number, about 0.25 millimeters. And so none of this is a coincidence, because this is a thing called temporospatial patterning, where some space is reserved for function throughout the body.
Well, I mean, the traditional view, though, it's kind of probably just become folklore and accepted, is sutures close up. That's it. As we get older, sutures close up. None of this is really. How, obviously, your response to that is
correct,
not so.
And based on evidence. And so we have to think about how science evolves, because science is observation, it's measurement, it's showing this is the reason why, and we're all very scientifically based to say we're going to make claims based on what we know so far. So the early anatomists, they had access to dried skulls. And so they looked at the sutures, and the joints were kind of fixed and looked as if they were completely closed up. And that was their conclusion based on what they saw. Downstream, we had light microscopes for the first time. And so people started to, make sections through these dried skulls, and they saw that the bones seemed to be, again, in fusion. The difference now is we have, 3D imaging that we do on living people. Now we go back and look at the skull, and lo and behold, we find there's a space between the bones, because there's blood supply, there are stem cells, extracellular matrix, all the small stuff that is lost when a body decomposes and dries out. It's very, very minute, but functionally extremely important. And so some of the new studies showed that if you were to stretch the sutures very gently, the stem cells will respond to that, and they will respond by making new bone and saying, I want to resist that stress and strengthen the skull. And so, we went back and looked at this clinically, and we found that we could actually increase the mid-facial bone volume by gentle stretch, by wearing a device inside your mouth for about 12 or 16 hours, gentle stretch, prolonged wear over a period of, let's say, 12 to 18 months. And so that is where the whole story really started to jive and take off, because if you've got good bony architecture, you're going to have a better functional response coming from that.
Now, it's worth also reminding our listener that the lower jaw is one bone, but the head is made up of many bones. And in fact, how many bones?
28. 28.
28, thank you. I knew you'd have that at your fingertips. But anyway, those bones are joined together, and that's what the sutures are.
Correct. Yes.
And you also mentioned, because we're going to come to that whole epigenetics in a moment, but you also mentioned that the brain is very delicate and is protected by fluid, and I think you're referring to the cerebrospinal fluid.
Correct. Yes.
Tell us a little bit about that. Pumps around the. How does that work? What is it? It is a static thing. It pumps around the body. What drives its motion?
Well, there is definite flow of cerebrospinal fluid, and our chiropractic colleagues are masters at showing the fluid dynamics there. It's an intriguing subject, and I'm not an expert in that by any means. But the point here is that none of this structure that we have is static; it's dynamic. Okay, and we need to have fluid flow, we need to have vibration, we need to have spaces, functional spaces to allow the flow to occur. Now, the thing about the human brain is that there are certain genes that we have as humans that no other mammals have. And so, when the human genome was actually sequenced, they said, we've got homology about 98% with chimpanzee, which means that about 1 or 2% of our genes are completely different, which is, so the question is, what genes do we have that the apes and the chimpanzees and gorillas don't have? And the answer is HAR. HAR is human accelerated region. And those family of about 6 or 8 genes, what they do is they allow this brain to grow rapidly and change its size and change its function. And so, this is where we need the fluids and we need the brain case to protect it. And so it's kind of unique. We have a very unique brain and cranial base that it sits on. And so a pretty complex, structure. It's just the way that we have evolved, and we need to really look after that and be cognizant of that, because some of the modern diseases like Alzheimer's, we mentioned multiple sclerosis, so on and so forth, dementia. What's happening to our modern brains that they tend to lose function as you get older? What's going on there? And a big part of that picture is airway, breathing, and sleep. And so now it's time to put all these bits together to say, you want a healthy brain, you better have healthy sleep. If you want a healthy sleep, you need a healthy airway. And so this is not a coincidence that these things are kind of lining up and saying, this could be the way to get people, optimized in terms of their health.
And a narrow airway would predispose us to dysfunctional breathing and sleeping.
Correct. So now when you think about a child, they've got a narrow airway, but their airway behaves differently from an adult who's got a narrow airway. And so again, it's this developmental dynamics that comes in. At which stage of life are you at for us to get a good working diagnosis? And so airway, the thing we're trying to prevent in all cases is airway collapse. Because if the airway collapses, the airflow collapses, you become deoxygenated, and that is when the damage is really done. And so the gold standard, if you will, is to say that we want to prevent airway collapse. So let's say you got a really big airway. There's no guarantee that you know how to use it. And so we can have a large nasal airway. We can have a good, pharyngeal airway, but we have to make sure that our patients know how to use the structure that they've been given. So mouth breathing needs to be deterred. Nasal breathing needs to be promoted. And part of that is tongue posture, tongue position. And so we have to get all of these bits lined up to get the best possible success. So we've got airway, we've got breathing, and then sleep is a physiologic process broken up into different stages, as you know. And so some people have a sleep disorder, such as narcolepsy, REM disorder, you name it. There's a whole 80, 81 different sleep disorders. So we have to differentiate.
Of which snoring and obstructive sleep apnea are one of those 80 or
Correct.
2 of those 80?
Correct. Yeah. Yep. So you've got
But 80 of these. So it's not just those. There's a whole range of them.
There's a whole range. And the funny thing, Ron, is that the sleep apnea part of it is highly prevalent compared to everything else. And so it's a bit like tooth decay. A lot of things could go wrong, but generally speaking, it historically was tooth decay. And so let's fix that problem. And now what we find generically is that if you have a sleep disorder, the chances are it's probably going to be sleep disordered breathing, such as snoring, upper airway resistance syndrome, hyperventilation syndrome, mild, moderate, or severe sleep apnea. And then you start getting systemic into things like fibromyalgia and chronic fatigue syndrome. And suddenly it's a very, it's a spectrum with no hard borders. It kind of merges, they merge and fuse into the different conditions. So severe UARS, upper airway resistance syndrome, might clinically present as fibromyalgia as the patient's main kind of concerns.
You mentioned airway collapse as being a key factor there, and I'm guessing that there are 2 aspects to what would predispose to that. One is size, and the other is tone.
Absolutely.
Are they the 2 main things we need to address in airway collapse? Do we have sufficient space? And do we have sufficient tone of the muscles around that area?
Yes, absolutely. And the other thing to think about is pressure differential, because you've got to have airflow. And so when it's the critical collapsing pressure. And so if you've got muscle tone, which is, robust, that airway is not going to collapse. But if you lose muscle tone, the pressure differential doesn't have to be very much for the airway to collapse in on itself. So muscle tone, we know that decreases as you age. And so that's something to be aware of, saying, okay, what can I do? It's just like going to the gym, working out, getting your muscles and bones into shape. The size of the airway, quote, size does matter, but it's more about behavior and functional. So let's say you've got an airway. Some people open and close their airway from front to back. Some people open and close their airway side to side. And some people open it like a sphincter, concentric, if you take a cross-section of the airway. And so when we think about a device, we have to say, how is this patient using their airway? What's the behavior of the airway before we decide to say, you're a candidate for X, Y, or Z, right? And so this is the more sophisticated bits that we didn't know 10, 12 years ago. We didn't know all this stuff. We know people who neurologically don't have a very good control of breathing. It's a feature called loop gain. And so
loop
yes,
gain.
So think about this, that you've got a thermostat in your room, and the temperature starts to fall, and the heating is going to kick in to maintain the temperature. The problem with the thermostat is that it doesn't respond very well. So you overheat the room, and then it kind of comes undershoots and it gets really cold again. Instead of having a nice, stable temperature, you get these big fluctuations. And some people, some patients have the neurological condition of, high loop gain. And so these kind of people are not going to be the best candidates for device use because it's more of a neurological issue. But having said that, that's the minority of these patients. as opposed to, the typical patient who comes to the office for, with sleep concerns.
You mentioned also, because we're going to talk about epigenetics in a moment, but you mentioned also mouth breathing. And I know this is a topic that we've talked about a lot on this program. Tell us what the problem with mouth breathing is.
I'll tell you in one word. It's 2 words: nitric oxide. Okay.
Okay.
Right.
Okay.
This is
yes.
yes.
Go on.
It's a classic. It's a molecule of the century. It does so much good throughout the body. It's got a short half-life, and so you need to produce it in a certain place at certain times to decrease inflammation, to allow regeneration. It plays so many different physiological roles throughout the body. And so what's the big difference? What's the big point with mouth breathing is that if you are a mouth breather, you bypass the largest storage site of nitric oxide in the body, which happens to be the maxillary sinuses in your top jaw. And so when you breathe through the nose, the air that's coming through your nose passes by the opening of the sinuses. The job of the sinuses is to produce nitric oxide. They store it there, they concentrate it there. So when the air flows by, it picks up nitric oxide from the sinuses and then delivers it down to your pulmonary alveoli in your lungs, and you get good oxygen exchange. And so if you're mouth breathing, you bypassed the nitric oxide pathway. And so you are breathing, but the real kind of, I'll use the word catalyst, is being, removed from the equation. And therefore it's not the best optimal breathing that you're going to get.
Now, Dave, I mentioned before we started recording that we've been reintroduced through Dr. Rosalba Courtney, who we've had also on the program several times. And I remember Rosalba saying to me something that was kind of a huge aha moment, and that was that 60, and I think I've heard more figures higher than 60% of the body's nitric oxide is produced in those sinuses only when you breathe through your nose.
Correct, but it's going to get picked up because the endothelial lining of the sinuses, these are the pneumocytes. The job of these pneumocytes is to produce nitric oxide. We have, the human body simplistically is a tube inside a tube inside a tube. And so the inner tube is endothelium. That lines your heart, it lines your blood vessels, it lines all of the viscera and the inner organs. And one of the jobs of the endothelium, healthy endothelium, is to produce nitric oxide. And so if you have inflammation, then that system gets kind of screwed up. And so the point here is that the largest storage site is the sinuses. Okay. And so it's kind of, why aren't we using it? Well, as you get older, your endothelium becomes aged as well and doesn't produce enough nitric oxide anyway. So what you can do is supplement that from the environment, in other words, with a nice healthy diet. And we can add some stuff to the diet, a whole bunch of foods. I'll give a couple of radish, beetroot, dark chocolate, I think tofu. There's a whole bunch of these foods which are high in nitric oxide once they're metabolized. And so that's another way to supplement that as part of your, keep fit routine.
I remember, and to put another perspective on it, I read an article in the Journal of Virology, very light reading it was, about the role of nitric oxide in disrupting the reproductive cycle of the SARS-1 virus. This was back in 2003. Yes. So it also has antimicrobial, antiviral functions too, doesn't it?
Absolutely. And this is why we prefer in the pandemic, we actually wrote a response to the American Journal of Dental Sleep Medicine. And what we said is that the devices that promote nasal breathing are more preferable to the ones that are going to either ignore that or promote oral breathing when you're sleeping at night, for the very reasons that you've just mentioned. So, there's a lot of work out there to say, here's the reasons why we want to promote nasal breathing.
Now, I remember when we met about over 10 years ago, you, in passing, and I made a big note of it, and I'm very grateful for this, said There was a wonderful book I should read. It's called The Biology of Belief. It would be a great introduction to epigenetics and introduced me to Bruce Lipton, who is a wonderful person who I've had the privilege of having a guest on my podcast. But the book on epigenetics, thank you officially for suggesting it, because it really was life-changing. Tell us about epigenetics and why it's so important.
Well, it's critical for human health. And so, around 2003, the human genome was completely sequenced for the first time. So we know which genes are required to make a modern human. But that's only part of the story, because even though the genes are there, they need to be read and they need to be functional to actually do their work. And some of those genes, they are there, but they're kind of dormant. And so the idea is, how do we get the best, response from our genes? And one of the examples, the most well-researched example, is methylation. So we have a methyl donor in our diet that is going to methylate some of these genes. And by so doing, the gene does its work so much better than it did before. And that's just a very simple explanation of the power of epigenetics. The beauty is that we didn't change the genomes. This is not gene editing. This is not gene, transference of any type. And what it is it's your own human genome, and we're getting the best possible outcome from your own genome. Since that time, we have now come into the age of CRISPR. And CRISPR, as you probably know, is gene editing. And so what we can do now is go in. Let's say there's a gene that's mutated. Let's take an example, cystic fibrosis. So the gene for lung function has been mutated, and the child is born with cystic fibrosis. What we can do now is go into the genome and literally edit that gene and say, I'm going to take you out and replace you with a regular gene, or I'm going to stop your function, and it's a done deal. And so there are many, of course, 25,000 genes in the human genome. But now, 10 years later, we have the technology to go back and actually edit the genome. We didn't have that, at least, easily available 10, 20 years ago. So that's a very different topic compared to epigenetics, which is much more kind of holistic. It's less invasive. It's using your own genetic potential to get a better result.
I think what I found most interesting about the Bruce Lipton story was, he made the point that thoughts are things, those thoughts being neurotransmitters, and they attach onto cell membranes and cause genes to express themselves.
Yep.
Well, if neurotransmitters can do that, so can environmental toxins, so can nutrients, so can other things have a epigenetic effect. What does epigenetics have to do with oral health and what your work does?
Well, it comes back to the nature of the signal. And so you can use, let's say, a chemical like, we talk about methylation, but the human oral structure has a very specific function: swallowing, speech, breathing, mastication, chewing. And so we have to be very well aligned in terms of what's in our mouth, what pressure is being exerted, and what effect it's going to have. So our signal is mechanical. Every time something goes into the mouth or teeth touch something, when I'm speaking, generally, I don't bite my tongue. And this is proprioception. I know where my tongue is in space, and I've learned that when I speak in this way, my teeth will not bite my tongue. So our epigenetic signal is going to be a physical signal, such as stretch, vibration, and also a spatial signal. So when your teeth are together, that's one signal. When they're apart, there's another signal. And so that is what we were able to do to say, let's get a series of signals which are specific to the oral cavity, but they're going to have an impact on human health overall.
Because you also mentioned earlier that these sutures, coming back to our discussion about sutures, because the fact that these sutures have a space of 0.25 or 250 microns or 0.25 of a millimeter, and that it is within those sutures that there is potential.
Absolutely. Again,
and yeah. No, please go on, because I think that is where these forces that you're talking about do their work.
Absolutely. And again, the literature has come in and really grounded and provided a very firm foundation for what we at that time were thinking this is how it will probably go. And so here's the deal: is that the way you mentioned the neurotransmitters, they have to go across the synapse to the other side to excite the other nerve. There's a space there. The suture has a similar amount of space there. In that space, there are populations of stem cells. So 10, 20...
Even in adults?
Absolutely,
Even in
yeah.
adults?
And so the papers they're all out there saying that the sutures provide a niche for the stem cells. And there isn't a huge amount of space there. But here's the deal about stem cells is when they get a signal, the first thing they do is they divide. The daughter cell will differentiate, and so the basal population is not depleted. Just think about your fingernail and the bed of your fingernail. It keeps on producing keratin, but the cells that are producing it are also reproducing themselves, and so you don't run out of stem cells. Your nails will grow, for the rest of your life. Okay, and so with the sutures, what we know now is that they are focal points, if you will, where stem cells are kind of concentrated, where they can be recruited, where they can differentiate, and when they differentiate, they'll make new tissues such as bone, but you need the appropriate signal. And so these stem cells have stretch-sensitive genes, very gentle stretch, a little bit of vibration, and those genes will kick in and say, time for this stem cell to become an osteoblast, and that's a bone-producing cell, so I can resist the tensile stress that I'm being exposed to.
And is age a barrier here, Dave?
It is and it isn't. Okay, the bottom line here is that the younger the better. Obviously, the child is actively growing. They've got great populations of stem cells. But, it's never too late. We've done patients in age of 60 years old, 70 years old, and even patients, into their 80s. And so really, it's a question of compliance, good diagnosis, clinical adjustments, and then see how this particular patient responds. Some people respond extremely well, really fast, and some people take a little bit longer, but everyone gets there in the end. And so, age is not really the arbiter here.
I know you presented recently in a published article that case of the 60-year-old male who'd had quite a few extractions. I mean, I think from memory, there were about 9 teeth that were extracted in total. So he'd obviously had orthodontics at some point in his life. And he had a sleep study done. I calculated he must have been in his late 40s when he had his first sleep study done. And it showed a pretty severe, it showed severe obstructive sleep apnea.
Correct.
And then he wore this snoring appliance for 10 years, which basically the standard approach to a snoring appliance. Tell us about what the standard approach to a snoring appliance is.
So we've got snoring and we've got mild, moderate sleep apnea. And so for that group of conditions, classically, they will give you a mandibular advancement device. And that's a device that really holds your lower jaw forwards whilst you sleep in an attempt to keep the airway open and not collapse. And so as long as you wear that device and it keeps your airway open, you should be fine. Now, in this particular case, it's very interesting because he heard about an alternative approach that I was teaching, and he decided to go back and get a second sleep study done. And
without his device,
And surprise, surprise, he was shocked to find that over a period of 10 years, his basal sleep apnea had actually gotten worse. It went from about 30 to about 68 or something. It was a big number. And so he became,
big number, big difference.
As long as he's wearing the sleep appliance that pulled the mandible forwards, he's probably going to be okay. But he realized that the underlying condition has actually got worse as he's getting older. And so he said, what's the alternative? Well, and as you pointed out, he'd had several teeth extracted. And so, we think that the bone volume was too small, and therefore by default, the airway wasn't at the optimal kind of, condition. So the idea was to redevelop the midface and hold the mandible forwards, allow the airway to remodel, and then see what happens. So we followed him for about a year. And in that time, the index of severity fell from about mid-60s down to about 10 or 12 after 1 year of proactive treatment.
Which was extraordinary, an extraordinary result. I mean, you know, when we talk about airway collapse, and with 9 teeth removed, his airway size would have been reduced. But as we get older, tone and pressure differential would have got worse.
Absolutely.
But here he was still at 60, 10 months or 12 months after your appliance, where there was just like about 2 millimeters. It was a small, not a huge amount, although relative in the mouth, that was quite a big amount. He had 2 millimeters of expansion, and like the result was quite extraordinary. I was taken aback by it.
Yeah, and it's not the first time. We've done this repeatedly. The point is this, Ron, is that when we make a measurement of 2 or 3 millimeters, it doesn't really mean a lot. What we think about is, what is the functional response to that? So let's give an example here. Let's think about a marble and a dice, right? So they're both the same size because they've got the same volume. But if you roll the dice, it kind of rumbles. And if you roll the marble, it rolls smoothly. And so the difference here is not the size difference, it's the shape difference. And so if you took 2 millimeters and then reshaped or remodeled, you know, the midface, the nasal airway, and the back of the airway, and you allow the air to flow more freely, that would give you a much better response in terms of breathing efficiency. And I think that's what's happening in these cases. It's the size, the shape, and the behavior. This is the influence that we are having.
And how would you, I mean, your appliance, I think, very timely name for it, Dave, is this mRNA appliance. It's a term that people are now becoming very familiar with. But what is the significance of the name first, the mRNA appliance, and how does it differ from a normal mandibular advancement device?
That is a brilliant question, Ron, and you hit the nail on the head, because the mandibular advancement devices, by definition, ignore the upper jaw. And the upper and lower jaws, they are always coordinated, okay? They have to be for function, for aesthetics, you name it. And so to say I'm going to bring the mandible forwards and ignore the maxilla, it's like leaving half of the story untold. And so the mRNA device was the first device in history that we can use even in adult cases to redevelop the midface in conjunction with the positioning of the mandible to get the results that we just talked about. And so that was it wasn't a huge difference, but clinically, it's the difference between a short, uncomfortable life and a longer, more pleasant life. If I can, put it in that way.
We've often said on this program, the secret to living a long life is to keep breathing for as long as you can. No big breakthrough there, but the secret to living a healthy life is to breathe well for as long as you can.
There you go.
And there's a big difference. Look, I think the whole connection between the oral, between the dentist and sleep medicine is so integrated. It surprises people that we are as a profession involved in it. And I just think your work is fantastic, Dave. I was so pleased to reconnect with you. Listen, you're a professor there. You're still in clinical practice, I assume.
Well, because of the COVID, we do a lot of work from home. I actually do my teaching online. So the next lecture to my residents is going to be this coming Friday. And it'll be done remotely. It will be done. And also we relocated twice since we last spoke. And so I'm getting to the point where I'm going to reduce my clinical activities, but at the same time be able to mentor, advise the best we can, and to help the younger generation really get to grips with the new technology, our new understanding, and help a lot more people, worldwide.
I want to just finish with one question that has not to do with your clinical work or your research, because we are as individuals all on a health journey through life in this modern world. What do you think the biggest challenge is for an individual on that journey?
That's a really complex question. If I use one word, I'm going to say lifestyle. And so, this is what I noticed when I came to the US, is that people are working so hard and such long hours that the quality of life tends to get faded away. It's like, guys, slow down, take a deep breath, and just, let's do something which is comfortable, reasonable, it's positive, rather than try to do, burn the midnight oil every night. It's about the quality of life and not really about the quantity that you have there. So simple things. And again, I'm going to talk from my personal experience. Let's look after our diet, for lots of different reasons, and pick a diet that works for you. A keep fit, program that works for you. You could go running, you could go swimming, you can do yoga, you can do whatever you want. Think about, your sleep pattern. Sleep is critically important for health. Okay. And then think about a way of relaxing, getting rid of stress, meditation, call it what you will. There are several factors that when they come together, you have a balanced life and you feel, okay, I'm in my zone. I don't want to overdo it. I don't want to underdo it. Where does that balance that works for me? I don't really different for so many people. I think we've learned that through the pandemic where we don't have to rush to a 9 to 5 commute every day. We can do a lot of stuff from home and be as efficient as we were before. The difference is if you're at home, I can go for a walk at lunchtime, get that real, sunshine, get that synchronization with the circadian rhythm, and then I can plan my afternoon and my evening and so on and so forth. So the simpler things tend to have the most impact. And so identify those for you as an individual, what works for you, and then go with that flow. Okay. And the body is very intuitive. The body will never lie. If you are tired, it means you need to sleep. If you're hungry, you need to eat. If you're thirsty, you need to drink. But the reverse is also true. If you're not hungry, don't eat. I'm sorry. Right? And so when the body will give you a very subtle signal saying melatonin release, I'm feeling a bit sleepy, I'm not going to watch the next episode on Netflix. I'm going to go to bed and sleep. So that, I think, the balance, I think, is one of the secrets that we are overlooking.
Well, what a great note to finish on, Dave. And again, thank you. It's been so wonderful to reconnect with you. And thank you for your fine work. And thank you for sharing your knowledge and wisdom with us today.
Well, thanks, Ron. Thanks for inviting me. I enjoyed it and we'll certainly keep in touch. Thank you so much.
Thank you. Right. Now, it's interesting. It may not have been that obvious to you, but Dave said that cleft palate, one of the causes of cleft palate, when he visited the particular area in Indonesia, the researchers realized that zinc deficiency had a significant impact on the incidence of cleft palate or cleft lip. Now, that's interesting, isn't it? A nutrient having that kind of an effect. And it's not particularly surprising because this relates back to the work of Weston A. Price, who was a dentist that traveled the world in the 1920s and 30s and was looking for the answer as to why tooth decay occurred. And what he discovered was much, much more than that. And that was that when he visited traditional communities living on ancestral diets that were nutrient dense, they not only didn't have tooth decay, but they had enough room for all 32 of their teeth in their mouth with some room behind their third molars, and that would have implications on the upper airway. And a nutrient dense diet was defined and he went around the world looking at all different diets. So what he found was that a nutrient-dense diet had 10 times more vitamins and minerals, of which zinc is an important one, of course, but there are many others. 10 times the amount of water-soluble vitamins and minerals, 4 times the number of fat-soluble vitamins like vitamin A, D, E, and K. And he also found, interestingly, that the best source of those fat-soluble, in fact, nutrients was from animals raised on healthy pasture. So this is all about a nutrient-dense diet, not only reducing your risk of tooth decay, but also ensuring that you have enough space in your upper and lower jaws for all 32 of your teeth and your tongue. Because if you don't have that, if you have narrow jaws and crowded teeth, you have a problem as to what to do with your tongue. you have actually 3 or 4 alternatives. One is you're a mouth breather. You keep your tongue down low in your mouth. You might have your lips slightly apart, but you would predominantly breathe through your mouth. You could, of course, walk around with your tongue sticking out, which wouldn't be a great look, and not many people do that, but this is an option. And the third alternative is you keep your mouth closed, but your tongue moves to the back of the throat and blocks the airway. And that may be a factor when you're awake, but when you don't have control over your muscles, it predisposes you to a whole range of sleep-disordered breathing conditions, of which snoring and obstructive sleep apnea are just 2 common examples. So this has tremendous importance, and we touched on there the airway, the collapse of the airway being the critical factor, and that being a function not just of size, but also of tone and pneumatic differential. That means the difference in air pressure between different parts of your airway. So it's interesting to have a discussion about epigenetics as well, and the fact that at these sutures, at these where cranial bones join together, there are in adults some stem cells. They're called undifferentiated mesenchymal cells. And if correct amount of epigenetic pressure, be it from your tongue or an appliance, is delivered to these sutures, it can stimulate growth. It can stimulate expansion of the mandible. And it's not limited to children, although, as Dave mentioned, it's best to get in early and take advantage of the growth spurt. But the case that I know he presented recently in the scientific literature was of a 60-year-old male, and that person had orthodontic treatment where they'd had up to 9 teeth removed. The teeth looked fairly straight, but the problem was the jaw was quite narrow, and by increasing the jaw width just a few millimeters, it made a dramatic impact on that person's sleep quality. And in our own practice, I know that we've done orthopedic treatment on people who, our oldest patient who had that done was 82. So, you're never too old. And I think this whole idea of looking at the jaw from a more holistic perspective, obviously something that I've been focused on professionally, and so have my partners in the practice for many years, brings into play the role of the jaw in sleep and breathing conditions and optimizing it. And also the importance of nitric oxide. That thing still keeps coming up. Now, I've heard varying assessments here of between 60 and 90% of the body's nitric oxide is produced in the sinuses, in the paranasal sinuses, only when you breathe through your nose. So when you breathe through your nose, you produce nitric oxide, then that is taken, the air is warm, humidified and filtered, but it also picks up on that nitric oxide. And nitric oxide is one of the body's most important regulators. It's a vasodilator, opening up the blood vessels, reducing blood pressure. It's a bronchodilator, opening up the airways. It's also antimicrobial, and that includes antiviral. So this whole issue of mouth breathing versus nasal breathing is an important one, and it was a great opportunity to speak to Professor Dave Singh. I hope you enjoyed that conversation. I hope this finds you well. Until next time, this is Dr. Ron Ehrlich.
This podcast provides general information and discussion about medicine, health, and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.